Un abrazo, igual.
Hi everyone, welcome to a Monty Hart lecture series. Today we had the great pleasure to have Dr. Roberto Lang, who will be speaking about advances in 2D and 3D echo beyond 2024, what I see in my crystal ball. It's a real honor to have Dr. Lang here today with us. He is originally from Buenos Aires, Argentina, just like myself. Has pioneered 2D echo, 3D echo, and has been present and pushing the evolution of echocardiography for many years now. He's currently the director of the non-invasive cardiac imaging lab at the University of Chicago. He's a professor of medicine and radiology at the same institution. He has published more than 720 manuscripts on cardiac imaging and physiology, written more than 120 book chapters, and edited 12 books during his career. Dr. Lang has been a pioneer in the development of 3D transthoracic and transesophageal echocardiography, which is a non-invasive technique that is currently used worldwide to diagnose heart disease, as we well know. He serves and has served as a manuscript review consultant and in editorial boards for most cardiology peer-reviewed journals. And his major research interests are the clinical utility of non-invasive techniques in assessing left ventricular contractile state and myocardial perfusion, and the use of three-dimensional echocardiography. He has served as the president of the American Society of Echocardiography and the current president of the National Board of Echocardiography, where he works with our own Mario Garcia. He also has been recently honored by receiving a named professorship at the University of Chicago, the A.J. Carlson Professor. So it's a real honor to have you here today. Thank you so much for taking the time, and we're looking forward to your lecture.
Well, thank you so much for the introduction. It's a pleasure, meaning I have been a friend of Mario Garcia for many, many, many years. And I think this is the second time that I'm giving grand rounds at your place. So let me start. Well, these are my disclosures. And we're going to talk a little bit about the future. And there are many, many things that are happening in imaging. Some of them are seen here in the slide, and that sort of makes a thing in an editorial that we wrote sometime that maybe the future has arrived, and are we ready to embrace the future in echocardiography? I always like to start these talks by showing this is Dr. Inge Edler. He is vastly known as the father of echocardiography. He comes from Sweden, the city of Lund, and you can see that our technique started in 1953. He was a lot inspired by the use of sonars in submarines during the Second World War. This is actually a little clip of Dr. Edler himself. He is here acquiring an echo, which is that black box. It was actually a box that was used to look at how pure minerals were. It was a Siemens sort of box. And you can see here that he is imaging the mitral valve, and you can see the anterior and posterior mitral valve leaflets. And you can move 70 years, and you can see how we are imaging the mitral valve now. So we have really, in a short period of time, sort of made a lot of advances. I was lucky that the first time that the 3D echo was done using a transesophageal probe, a matrix TE probe, was done at the University of Chicago, and was here in the year 2007. And of course, our surprise was huge to see that you see the mitral valve similar to what the surgeon sees on the mitral valve. And you can see also nicely that this technique, very few things in echo have been so quickly accepted. And this is one of them because I think physicians sort of see the utility of this technique. So when we talk about 3D imaging, I'm going to make sort of comments on the 3D acquisition, the analysis, and the display, talking mostly on what are new things. And I think one of the new things that happens in 3D echo now is the advent of new transducers that have revolutionized the quality of the technique. Here you can see the same patient imaged with an node and a new transducer. And you can see, of course, how much better you can see the definition of the endocardial border. But when you take this data set and cut it, slice it, similar to what you do with an MRI, you see interesting here how nicely you can see with a new transducer the borders, sort of getting closer and closer to what you see with an MRI. And you just glance and see the difference between these two transducers. So this has left us to the idea that if you have a transducer like that, you could acquire a chunk, a 3D echo, and then, of course, as we always do, you can slice it and make the different sort of 2D views appear. And the idea is that if you had a chunk and with AI, you could go and cut it, you can see these 2D echoes have all been derived or obtained from this 3D echo volume. And you can see now that for the first time, the quality of these 2D echoes approaches the quality of a transthoracic 2D echo. So you can start thinking that if I acquire a full volume of data and I could immediately using AI cut it like you do here, obtaining the apical 4-chamber views, or how I do here to obtain all the short axis views, you can start thinking that if you acquire 3 full volume acquisitions with 3D echo, you can immediately have a display of a regular 2D echo. So that's one of the things that we've been working with, which I think is interesting now, developing the AI part so that these acquisitions can be done automatically. So let me now talk to you about something that is close to my heart, which is how to improve the quantitation of the mechanical properties of the ventricle using 3D echo. For many years, we have shown that people, I think, already understand that 3D echo is more accurate than 2D echo for the calculation of volumes. And the main reason for that is that with 3D echo, you can acquire a true non-foreshortened view of the left ventricle. So you avoid all these foreshortening errors. And the other thing is that if you have a segmental dilatation or a wall motion abnormality, you can capture it much better with 3D echo. And here you come to one of the first studies that we were lucky to publish using AI, in which the idea here is that you get these full volumes of 3D echo, and you actually train a computer by providing this computer with thousands of these images. The computer is then able to find the endocardial borders within this volume and create a generic model of the heart. This generic model can be then locally adapted for variations in dropout and clutter and so on, and you can then obtain a final model. Now, the idea is you need to really give the computer many, many data sets because, as we all know, the ventricle comes in different shapes. Sometimes they are dilated, sometimes they have more of a banana shape, sometimes they have a prominent sigmoid, and sometimes they have this prolated ellipse type of shape that we think. So this is an example. This is something that probably you have seen in your use, which is the fully automated chamber quantitation, in which you can look at the changes in volume versus time of both the left ventricle and the left atrium, with the advantage that the left atrium is also acquired and modified by acquiring a non-foreshortening view. And you can obtain simultaneous LV volume curves and left atrial volume curves. When this was being developed, we thought that we could probably do the 4 chambers of the heart at the same time. But this is sort of difficult because, the full volume, many times if you have a dilated heart, does not fit. But this is just to show you an example here of this is a different vendor to the images that I showed you before, in which this vendor has now captured and has the ability to give you the volumes of the 4 chambers at the same time. So you can see here data not only of the volumes of both chambers, but also strain of the left ventricle and the left atrium. So that's something that I think has a lot of potential. Other potential is, let me show you, this is an example of a patient who underwent mitral valve repair. Preoperative, this patient had severe mitral regurgitation, and you can see that the ventricular shape grossly looks like a soccer ball. This patient was operated successfully, and you can see that even at 6 and 12 months, the shape of the ventricle changes quite a lot to become much more of a American football. So we have developed a lot of methods that allows us to look at the curvature. This is a 3D endocardial reconstruction, and you can see all of these points. And if you calculate in each of these points the curvature by fitting a circle and obtaining the inverse of the radius, you can then color code the outside of the ventricle to create a parametric display. And this is an example of a normal subject. You see a patient with a dilated cardiomyopathy, how the curvature of the septum changes. And this is, of course, a patient here with an anteroseptal wall MI, which you can very nicely. So we are very excited. I have now finished a study on 2,000 something patients showing the changes that occur in shape of the heart with as you become older. Another thing that we've been working very nicely is that with the use of 3D echo and dynamic endocardial reconstructions of the ventricle, it is possible to non-invasively recreate pressure volume loops with some formula to obtain the end-systolic pressure volume relationship and the end-diastolic pressure volume relationship. With this, you can, of course, calculate non-invasively the stroke volume, the stroke work, and the potential energy. So this is also another area that I think we are working very nicely and has a lot of potential. So let me shift a little bit to the right ventricle. The right ventricle has a very funny shape. It has a crescent shape, and it doesn't fit any geometric model like the left ventricle. And you can see that in order with 2D echo to assess the right ventricle, we need to obtain multiple 2D views, and then we need to integrate that. I always like to show this slide in which you can see the 2D echo plane with a 3D echo, and you can see the cross planes here of the 2D echo. These are the parts of the right ventricle that we usually see with a 2-dimensional echo. And you can see that there are many areas of the apex of the alpha tract that you are not imaging them with 2D echo. Over the time, we have also now found that this is a very reliable and accurate way to estimate right ventricular volumes, and that these right ventricular volumes and ejection fraction are sort of very good predictors of outcomes in various conditions. This is the similar AI-derived problem of the left ventricle now applied to the right ventricle and eventually to the right atrium that allows you within seconds to section the right ventricle in multiple short axis views and then obtain from this the right ventricular volume. And this is also, I think, a very exciting type of work that with these endocardial dynamic reconstructions of the right ventricle, you can now do quite a lot of modeling, and you can decompose the ejection fraction of the right ventricle into the longitudinal ejection fraction, the radial, and the anteroposterior. And the same you can do with this 3D strain. You can divide it into both circumferential and longitudinal strain. That, of course, is sort of very interesting because if you take, for example, a patient with pulmonary hypertension versus a patient with pulmonary regurgitation, pressure overload versus volume overload, you see that in the patient with pressure overload, the majority of the right ventricular strain is done on the longitudinal direction. On the other hand, when you look at volume overload, you can see that the majority of the strain occurs on the radial direction. So this is yet another area which I think is sort of very interesting. The same as I was showing you about the right ventricle, we were exploring the possibilities of looking at the shape of the right ventricle. And we have all now understand the differences between atrial secondary TR and ventricular secondary TR. This is an example of atrial. This is a patient with atrial fibrillation with a very dilated annulus of the tricuspid valve, in which you can see that there is predominant atrial dilatation when compared to the ventricle. And if you look at this and imagine this in 3D, this looks like conical. And if you take a patient here with ventricular secondary TR, you can see again that now there is not disproportionate enlargement of the right atrium. Both are enlarged in a proportionate way. And because the ventricle is also dilated here, you start to see the tethering of the tricuspid valve, which you did not see. And this, if you think about it, as more of an elliptical model. And these are just some of these studies in which we look at the shape of the right ventricle in patients with atrial fibrillation. You can see that the right atrium is dilated. You can see that there is no tethering, and you can see this conical shape. In pressure overload, which is more ventricular secondary, you can see this elliptical shape. And you can see these differences here in which you can see the conical remodeling versus the elliptical remodeling. And we're hoping that as we develop these models, we'll be able with medications to sort of quantitate remodeling. More futuristic and important here is the fact that if I have right ventricular pressures, which can be obtained either invasively, but now with AI, non-invasively, and I have also the right ventricular strain, I can create these pressure strain loops. And if I also have 3D RV volume, I can create these pressure strain volume loops. And we are sort of very excited about this because we can think about now that everybody's interested in looking at tricuspid regurgitation. You can see that you can take these patients from normal LV function and to decompensate it and sort of try and understand much better the physiology of the right ventricle. So the point I'm trying to make is that you can really now improve on TAPC and the S wave as ways, very primitive ways of estimated right ventricular function. So let me just go now and talk to you about what have we improved on the display of the right ventricle. So in many institutions, we have now these newly created valve groups that usually are made by interventional cardiology, imaging, cardiac surgery, vascular surgery, and cardiac imaging. I always like to show this slide. This is one of the first TAVRs we do, and if you count, there are 17 people in the room. That's why American medicine is so unbelievably expensive. So 3D echo is sort of very interesting because 3D echo was developed at the same time that structural heart disease. Then they got to know each other and they got married, and a divorce is not possible. So you can see that a lot of these potential things that we do with structural medicine or structural interventions are all very dependent upon the visualization of a 3D echo. And there are many of these possibilities, or, clipping of the mitral valve and the tricuspid valve. And, when we have a perivalvular leak, transeptal punctures, etc., all of these, without 3D echo, you would not be able to use them. And therefore, we have seen futuristically all of this software developed in order to measure, for example, the mitral valve. These are examples of, again, automatic. A lot of this also happens now within seconds, in which you can see the location of a prolapse in P2 and P1, and you can measure the area, the malcoaptation of the closure line. You can measure also the height of the saddle-shaped mitral valve. And interestingly, this is some software we have developed with some Italian engineers from the University of Milan, in which we are looking at the regional strain of each of these valves. And that, I think, is going to be very interesting, because the idea is to restore the regional valvular strain to normal after we do a certain intervention. So, one of the problems that we're confronted with 3D echo is the fact that we talk about 3D echo structure, but we always show it in a flat screen. And in order to get this idea of depth, we need to color these data sets. So from here, came this idea of introducing a source of light into the data set and move it around in order to create shadows that would improve our perception of a 3D echo. And this is an example of a prosthetic valve in which you see two of the leaflets are fused. And I'd like to show this slide. This is a patient after a clip. This is the regular 3D echo. This is the 3D echo in which we have colored and introduced a source of light. And you can see that as you improve this data set and also incorporate some transparency to this data set, how nicely you can see these Alfieri holes here. And you start seeing the clip that before has been difficult to see. And this is, again, something that I think is interesting. You can very nicely, with this, improve the visualization of catheters as they pass the tricuspid valve. You can see that this catheter is impinging upon the mobility of the anterior tricuspid valve, leading to tricuspid regurgitation. And this is, again, this technique showing how you improve the visualization of the left atrial appendage. Look how nicely you can see here the left circumflex coronary artery, how poorly you can see it in a regular 3D echo, and you can see here the muscles very nicely of the left atrial appendage. I am excited because into the future, as I showed you at the beginning, with the improvement in the quality of the data sets, that this is a patient with a flail anterior valve, and this is the same finding in a transesophageal study, and now you can start seeing these same findings with transthoracic echocardiography. Look at this is a patient with a flail P2 with 2 ruptured cords. This has been obtained with transesophageal echo, and you can see the similar image obtained now from a transthoracic point of view. These are all the possibilities that can happen as you increase the quality. One of the things that we've been also working on, which are going to happen, is, the echo is very good at assessing the stenosis, but not so good to assessing the regurgitations. Mitral regurgitation, we all use the PISA method, and we're going to talk about it, but this flow convergent method is based on incorrect geometric assumptions. First of all, that the orifice is fixed, that the flow that has a certain orientation, et cetera, et cetera. So these are all relatively, so we have been working now almost for 2 years to try and develop a new method to assess mitral regurgitation that is based on 3D color Doppler. And 3D color has improved tremendously, and the whole idea behind this method is that we have these many times slit orifices, not an orifice that is circular like Pisa would like it to have. And if we use many of these pinholes in this orifice, we can create a computed flow convergence flow model that we compare to what we find, and we can reshape if necessary. And this is a little bit how this looks. We're looking at this dynamic orifice. The whole idea of this is that you would be able to obtain values of regurgitant volume throughout the cardiac cycle, the same as measurements of effective regurgitant orifice area in the vena contracta over time. And just to show you an example, this is how this looks. You can see in diastole the curve of regurgitant volume. We can see that in patients with degenerative mitral valve disease, this curve are diphasic. When you have functional mitral regurgitation, there are only one, and you can see here how we have overimposed the true flow with a flow that has been deduced by the computer. And just to show you this, let me see. Okay. So this is an example of a patient obtained after a clip. Calculating or measurement of mitral regurgitation after a clip is very difficult because you have more than one orifice. And here you can sort of put everything together. You can see in this particular example how flow goes on the two parts here of this clip. And you can see these areas of flow convergence and how they are being quantitated. So I think all development of all of these methods are going to happen pretty quickly. I think another big advancement that we have seen is, as all this tricuspid structural heart disease is being developed, we all have to learn how to image the tricuspid valve better. And here we see, from a transthoracic study, looking at the tricuspid valve as I would be in the apex of the right ventricle and look up, I can see nicely the three leaflets. These three leaflets from a transthoracic study, you can see probably in only 5% of the patients. With 3D echo, you can see the three leaflets. And from this, we sort of learned that many times the tricuspid valve is bileaflet, and sometimes we see that the tricuspid valve has 4 leaflets, etc. If you start imaging these things, you would see, and this is very typical case. This is from a publication of Dr. Becky Hahn, and you can see that she has proposed a classification. The most common type of tricuspid regurgitation is that in which you see the 3 leaflets. 3B is the category that is the second most common, in which, as you can see here, you have an anterior leaflet, a septal leaflet, and you can see that this posterior leaflet is divided into a P1 and a P2. And this would be the similar, which is a 3C, in which the septal leaflet has 2 parts in it. You can see that the septal leaflet is. So these are all very important things. I would always tell people that you have to learn all of these images are acquired from a transthoracic point of view. The tricuspid valve is easier to acquire from a transthoracic point of view. And there is also now software that allows you to, in seconds, to obtain semi-automatically in a dynamic way the tricuspid annulus, which is very important to have this quantitative information for the placement of these evoke valves. Again, you can see that the tricuspid valve has a saddle shape, and we have quantitated, projected areas and perimeters for a lot of patients. Another very, I think, new thing that is happening is, we have seen now the classification, the same as we did for mitral regurgitation for many years, of tricuspid regurgitation. And we talk about primary TR, and we talked about secondary TR, but now a discrete and separate cause of tricuspid regurgitation is the TR that is related to pacemakers and AICDs. And here, 3D echo is really important. This is what we see in a 2D echo in a lab. We see that there's a pacemaker, we see some TR, and that's as much as we see. With 3D echo in this same patient, you can see this catheter here impinging upon the septal leaflet, resulting in mild coaptation of the tricuspid valve. So there is quite a lot of more information. 3D echo also helps us. This is the same patient in two different views. In this view, with no change, you can see that there is coaptation. Here there is mild coaptation. Here there is not a lot of TR. Here there is massive TR. So with 3D echo, you know where you're making your cuts. You can see that in this portion of the valve, you have coaptation, and in the green plane here, you have mild coaptation between the anterior and posterior leaflet of the tricuspid valve. Another thing that we can look with 3D echo in the tricuspid valve is when a catheter results in tricuspid regurgitation, not because it's impinging, but because it is fused with the valve, leading to an incorrect motion of the valve. 3D echo, you can see this pacemaker is actually moving with the motion of the valve. And let me show you how this looks at the time of surgery. You can see this catheter is completely fused to the tricuspid valve, leading to tricuspid regurgitation. So I think a lot of newer things in the way that we display the valves, and a lot of newer things in which how we quantitate both the mitral and the tricuspid valve. So let me show you a little bit now, ending with 3D display. And we have many times tried to improve the way that they visualize a 3D object. We go to the movies and we have seen the use of these stereo glasses. People have proposed the use of these stereo monitors, which are very good but extremely expensive. We have seen for a while the use of 3D printing, which is pretty good. There's a patient with a cleft mitral valve. Problem with printing is that you can acquire a model in one moment of the cardiac cycle. And a lot of people are now working with the idea of creating a holographic display of the heart. So, we had this idea of trying to convert a 3D data set into a virtual reality type of data set. And, we have seen a lot of this virtual reality or has been sort of developed predominantly in the gaming industry. And therefore, we have a lot of software that is available, and we have all these eyeglasses in order to look at things, understanding that virtual reality is a reality that does not exist. When you put these glasses, there is no real world visible, but you have really a reality. Then we have another type of this that is called augmented reality. This is, for example, a desk in which you have a model of the heart, that you are seeing the real world at the same time. You're seeing the desk. This type of model would be extremely useful if you wanted to further explain findings to a patient. So we have a little lab here in our Echo Lab in which we have these room sensors that create an area in which we can do virtual reality. You have these headsets and controllers in order to move these data sets, and you need to have a computer. Now, since I made this slide, nowadays you don't need to be tethered to a computer. All of this works wirelessly. But this is sort of our little lab in which we are doing this type of work. Meaning I went to medical school in Argentina many years ago, and the way that we learned anatomy was looking at cadavers, and that's how we learned. This is a clip that was lent to me by the Cleveland Clinic, in which you can see medical students using virtual reality in order to learn anatomy. So you can get the whole structure, you can peel it off, and you can move it. Meaning the ability to learn is so much more didactic than what you would do in the way that we used to learn. This is at the American Society of Echo, sort of a year ago, in which we gave a class, first time in which we did a sort of a course to teach physicians how to use and look at virtual reality. And they're all looking at the same sort of data set. You see how concentrated they are. This would be a great time to come and steal some wallets if you want to. Nobody would figure this out. But you can see that this virtual reality would be a way that would enhance education and training, would enhance the ability to communicate with the surgeons and with the patients. So let me show you now. This is a data set. This data set is difficult in a talk because as I extract this data set from the screen and make it float, this data set is as big as the room that you're sitting in. So you can modify it. You can nicely see that one of the leaflets is moving. You can actually touch it, and you can also do any type of measurements that you want. This is made now from a CT. Let me just go back. You can see that in this CT, I'm going into the heart. You can see the papillary muscles. You can move your data set and go into the left atrium, in which you see then in a little bit the offtake here of the pulmonic veins. You can turn this data set around, and you can look now at the apex of the heart and the papillary muscles. All of this, you have to understand that it is as big with, you have the lens, is as big as the room that you're sitting on. And we're now working, this is an en-face view of the left atrial appendage. And you can see here we're making measurements. So with this, you could truly understand the annulus. You understand that even though you're making a measurement on a 3D structure, that 3D structure is not completely straight, but it follows the motion. And you could then, based on that, go to the shoe shop and get the correct occluder. You can place this occluder and see how it fits. So I think this technique has a lot of possibilities for or potential to look at at the simulator. And this is sort of very initial work to look at simulation of both the mitral valve and so on. You would have to really see these with the lenses to sort of understand the capability, again, the ability to take the valve that you have measurement and then place it in the position and see how this fits. This is a little bit the vision. You are now reading echoes, and wherever you read your echoes, you have a list of studies. Any study that you want, you click a button, and in seconds, you have a 3D data set. You can put all these lenses, and you can extract this data set from the screen, and you can visualize it. So you can see here it is being extracted. If you look in the bottom left, you can see the motions that you need to do in order to visualize this data. You can make it move and so on. So this, of course, has, I think, the advantage that you can do it as you're reading echoes whenever you have a 3D echo acquisition. And this is not a truly expensive new modality. So with this, I think I will be finished. I just let you know that, every time that in echocardiography we think that things are done and what else can come, there is always new things. And I think that, the next decade will be completely caught by artificial intelligence, which is unbelievable, the amount of things that you can do. And I think that that will totally change the way that we do echocardiography, but also all the other imaging modalities. So for that, I would tell you again, the future has arrived. Are we ready to embrace it? And with that, I want to thank you for your attention.
Thank you, Dr. Lang. That was amazing. The future is definitely bright, and it's amazing how you've gone through all the phases of echocardiography and how you're embracing the future as well. So congratulations for that. We'll start with questions now. If you have questions, please place them on the Q&A section. Maybe Dr. Garcia would like to start with the first one.
Roberto, that was an incredible overview. I want to say that I think of what we appreciate today in modern echocardiography, at least 75% is due to some of the developments that have come from your lab. So it's really impressive what you have done career-wise. Yeah, I'm just curious about the way that you're obtaining the 2D data from 3D data sets. I mean, one of the limitations of echo, as we know, is that the pixels are not isotropic, right? The ultrasound beam diverges and widens as it moves away from the transducer. So, part of the reason why we have multiple windows in echo is because we see the aortic valve better in a short axis view. We see the apex of the left ventricle better in the apical views. When you're using this 3D approach, are you using a single acquisition from one window, or is there a way to integrate data from multiple windows?
Yeah, that is a very good observation, which I agree entirely. So there is actually now software that can cut it for you, so it can find the mitral, the tricuspid, whatever you want to see. We obtained this from 4 different acquisitions in order to avoid that. So it's not from a single acquisition. So we obtained 4 different full volumes, and from that you can do it. The disadvantage of that would be that you cannot integrate Doppler. So you would have to you can't integrate the Doppler into the 3D. You would eventually be able to integrate the color Doppler. So but there's more to come, because I think with a new software, you can acquire a full volume and press a button. It will take all the 2Ds and display it. And you can see already from the other presentation, or the other thing is that they know how to find the different structures from this piece of 3D echo, right? With AI, you can do that.
Thank you very much. Very good point. I have a question, and then we'll go through the Q&A. We still see in reports, and I'm sure you do as well, when people talk about dilation of the ventricles or remodeling, the use of single measurements such as the LV and the stone dimension, and people make decisions on valvular disease or cardiomyopathy on this. And the concern is obviously the eccentric remodeling and some of the things you've shown. Should we just move away completely? Are we ready yet to drop that? And what's your approach?
Well, in the meantime, I like developing sort of the method. That's what I like. But then you have to prove that obviously a 3D approach is better than a single approach. I'm sure it will, but these things need to be tested. And in order to be tested, people have to embrace and learn how to do a 3D echo. If you don't do it, you can't use these type of things. So there is more to see. I think people are slowly, from a T point of view, 3D echo has been accepted. Everybody, because you have to use it in order to do structural. But the transthoracic, you can still not do it and get the study done. If you know what you're doing, you can do it pretty well. So that is something that in order to do a lot of these shape analysis and things like that, more people would have to embrace it and acquire it and do these type of things.
Thank you very much. And related to that, from Edwin Ho here, he says, thanks for the amazing lecture. Have you incorporated routine 3D LVRV acquisition in your echo lab for transthoracic studies? If so, what were the challenges or barriers you encountered?
Okay, that's also a very good question that many times people ask. Meaning, having 3D echo in every machine you have costs money, right? And whatever, even if you do a lot of research, it costs money. So we are probably smaller than you. We I don't know how many. We have 17 machines, and I think maybe 14 of them have 3D echo. The other ones don't. So we have yes, we do routine LV and RV 3D echo. It's complicated because the way that we did it is, we have 4 or 5 sonographers that are excellent. The other ones are, more average, good clinical sonographers. So we took a lot of time to teach one at a time to do it. So, we have been doing this for a long time, so it's easier for us. But we use this heart model almost in every patient. And then it's up to the reader because many times, if you do it very quickly, you might not agree that volumes that are given are accurate. So you can either change them, but nobody has time to do that, or you erase them. So yeah, the idea is we try to do it. I think, and I'm sure it's the same thing in your place. We do 3D echo in every TE that we do.
Yeah. And thank you very much. We're not doing 3D in all transthoracics here.
No, that's
but yeah, but the TE for sure. So we have a question from Daniel Lorenzati. He says, thanks for that wonderful journey. Another Argentinian here with us. He says, given that cardiac MR and 2D echo use similar biplane methods, why do we consistently see higher atrial volumes on CMR? Data from waves suggests higher upper limit of normal for the LA volume than the 2016 ASC guidelines. He asks a very good point, I think. Are we systematically underestimating LA volumes with 2D echo, and could a 3D heart model help with this?
So that's a very good question that I always like to talk about, which is that, when we did the first quantitation guidelines the year 2005, we got an LA volume that was like this. 15 years later, the LA volumes got bigger. And then we were, now we can write a new quantitation paper. It's like the stock market. The left atrium goes up and down. And the reason for that is that in the newer paper, people started to figure out that you can't acquire the left atrium and the left ventricle at the same time, because you acquire a non-foreshortened LV, and then your LA is very foreshortened because the long axes are not parallel. So what you end up doing is you have to get a non-foreshortened view. When we did the ways, we instructed everybody to do non-foreshortened views. So you do this non-foreshortened views, and now the left atrium is going to be bigger. And when we write the new guidelines, which are being written now, the LA volume is going to go big again. The LA is like a cylinder. So 3D echo, if you acquire a biplane non-foreshortened left atrium, the volume is going to be pretty similar to the MRI, and 3D echo does not give you any advantage. So the whole key here is not to do 3D echo. The key is to do the acquisition in a non-foreshortened way. And when we did this heart model, you take a 3D echo, and then you can tell the computer to display the left atrium in a non-foreshortened way and do the calculation there. So that was why this model, I'm sure that we still would be underestimating against MRI, but less. But the whole thing here is just the acquisition.
Thank you very much. I think Mario has another question. You're muted, Mario.
Yeah, actually, I was going to make a comment on a question on your approach to actually move away from the PISA to I guess, a open geometry approach. to calculate flow across the mitral valve. We certainly share your observation that PISA only fits mostly in degenerative mitral valve disease, but not in other type of MRs where tends to underestimate MR severity. Not seeing now more precise left ventricular volume with 3D. Why not just to use the CMR approach, the difference between the volumes of the left ventricle and the flow across the left ventricular outflow tract?
Yeah, that is something that we are actually doing. So what you say is absolutely true. And I remember many years ago, you taught us this when you came to the University of Chicago and taught us CT. I always remember that still. But yes, we're doing that because, you know, when you do this research on valves, it's very complicated because what do you compare it against, right? You cannot compare it with an MRI because it's very difficult to do an MRI and a TE the same day without, meaning it's impossible. So we are using this approach. Actually, we are writing an abstract now to the ASC exactly what you're talking about, of using what we call the volumetric approach, which would be the MRI approach, based on 3D echo.
Thank you very much. I have one more question. You spoke about different uses of AI. What's the status on the AI for the acquisition for sonographers to get this and foreshortened views? And I know there has been some softwares that have been proposed. Have you used any or?
So there are like 6 or 7 companies that have software to guide people to acquire, but they're pretty non-sophisticated. So it allows you to acquire a bad apical 4. It doesn't really teach you how to obtain it so that it is non-foreshortened. There are some software that allows you to, they look at the quality and tell you that, but there is more work to do with that. So, you know, yes, there's a lot more work to do with that.
Okay, we'll have to wait a little bit more then, I guess. For okay, well, thank you very much. This was wonderful. Hopefully we'll see you. Are you going to ACC? Or
Yes.
Hopefully we'll see you around.
Okay, and thank you, Mario. Thank you, everybody, for inviting me. A pleasure to be with you. Thank you.
Bye-bye. Thank you.